Thank you, Adrian, and thanks to all the other speakers for most informative talks. There's been a lot of information to absorb. Okay, we'll move on to questions now, and I'd like to bring up some COVID questions in a second, but can I throw just one quick question to Rob Costa? The Cancer Drugs Fund, which you mentioned, is this time limited? So if a patient is given treatment under the auspices of the Cancer Drugs Fund, does that carry on forever, or is it time limited?
It's time limited in terms of as long as it takes it to get through the NICE process. So because it's not always the end of the NICE process, if you get what I mean. So I use CAR T at the moment. So with CAR T, for the treatments it's available for is on the Cancer Drug Fund, but it's why we gather more information on outcomes and that sort of thing. And if it turns out in 2 years' time that the outcomes of these patients is really poor and we decide to effectively decommission it because it's not as effective as we are led to believe or that sort of thing, then it'll come out of the Cancer Drug Fund and it might only be commissioned in certain certain cases, and we might restrict it a bit more. So it is, yeah. So I suppose it is time limited in the length of time it takes for it to become available as a standardized treatment.
Okay, can I move on to some COVID questions now, because we've been inundated with questions about COVID quite clearly. Adrian, one question is, should I consult my medical team about my level of risk from COVID? I'm on watch and wait, but expect to start treatment soon.
Yes, I think the whole thing here is about trying to assess levels of risk, and it's extremely difficult to do. I think context is very important here. If you look at the literature for COVID risk in CLL patients, it paints a very gloomy picture. And some of the publications have suggested very high mortality rates of between 30 and 40%. I think it's very important when looking at that, though, that it's that is COVID patients in hospital, so they've got more advanced disease, and mindful the background rate, the COVID mortality, if you're admitted to hospital, irrespective of CLL or anything else, then actually it confers a significant mortality. The other is that most of those patients were older, typically had other medical problems. So it's an inherently higher risk population. I think the data would suggest, as much as we know, is that CLL, irrespective of whether you're treated or untreated, increases your risk over and above whatever it was, but it's important to look at what the denominator was. Clearly, in somebody who is older, who's got other medical problems, then adding treatment into it is a potential concern. In somebody who's fit and in their 50s, their background risk isn't actually that great, and it might not be increased that much more. I think it's also important to think about the treatment that you're going to have, and this is one of the things that we look at in terms of trying to make the choice. There is a suggestion perhaps that ibrutinib or BTK inhibitors may not be associated with such a big risk as we see with chemotherapy. And this is certainly something that we've looked at. And I think many people, or people who've had treatment recently, may have been aware that we've had access to acalabrutinib, for example, as a frontline therapy for people who are not suitable for chemotherapy. And I think this is something of trying to nuance things. Going back to March, we stopped treating people. Many people, it was all that we didn't know what was going to happen with COVID, and they were sort of, let's stop, reduce it. Now I think it's an acceptance of the fact that COVID is going to be with us in one form or another for many months, and therefore I think for those people that need treatment, it's important to not put it off unduly, because if you need treatment today, I can't say when the COVID risk goes away. Is it 3 months? Is it 6 months? Is it a year? We don't know. And so I think it is really important to have that conversation. And I think that's something that as clinicians we're all doing, of trying to say we need to be giving people with CLL their treatment, but equally trying to minimize it. What it will mean, though, I think, is that the adherence to COVID precautions becomes ever more important. It's unclear. Is strict shielding really necessary? Well, quite possibly not. But equally, I think you've got to risk assess everything. You can't catch COVID from being outside with no one else around you, but thinking about situations, be that who's in the house, whether you're going shopping, is there anyone else there? It's not a time to be saying I'm going to go on a long haul flight or to, go out with disregard. It's vague, Brian. I can't give you an answer, but that's how I approach it.
Fine, thank you very much indeed. Following on from that, we've had a lot of questions, which are very simple, really. Is it safe to go into the clinic for treatment at the present time? One person is on FCR. Could I take an oral treatment instead?
I think for those people on treatment, I would carry on with treatment if it's working. I think it's difficult to say that we would be it'd be probably disadvantageous to say we would change something. I can speak for what we do here at the Christie. What we've spent is we've invested our effort as a cancer centre in trying to create ways to be able to treat people safely, not trying to find ways that we can't do. And I think most hospitals are looking for this, of saying they're very much segregating. We've got green areas and we've got not green areas. We don't put our COVID patients with our non-COVID patients, and particularly in cancer centres. So, we have been doing routine staff testing since March. We're testing patients before they start treatment, and we've got a low background rate. So I think, it depends at individual hospitals, but I think, yes, the strategy that we have at the moment in most hospitals is trying to create a safe environment. And I think that most people have been able to achieve that. And as I said, it's important to be giving treatment if that's required. I wouldn't change, though, if somebody's on it and it's working.
Okay. Have you had to adapt the clinics because of, for example, for teleworking and so on, teleconsultation? And do you see that continuing in the future as a beneficial thing?
Yeah, that's been the low-hanging fruit of things, actually, that we've been talking about telephone consultations for a long time, and there would always barriers put up to it. We wouldn't like it, patients wouldn't like it, we didn't have the technology. And actually we found that for a lot of people, particularly those people who are on surveillance, they don't need to. They find it convenient. They don't want to travel an hour and a half to come in to be told that their blood count's the same as it was a year ago and that very good, everything's all right. It's more difficult with people where you've got tricky decisions when you're coming to treatment or when they've relapsed or experiencing toxicity. So I think that my feeling is that we will be continuing with telephone consultations. The feedback we've got from lots of people has been very good. But I think it would be good to move away from it, that we don't want to be having, a new diagnosis discussion with a patient remotely or somebody who's not supported by a family member. I think that's been a real downside to it, of not being able to give that support. In terms of practical things, it's a space issue. So we've had to reduce the numbers of people coming through the day unit, through the clinics, in order that we can maintain distancing. And that's coming back to the previous question about how we can give treatment in as safe a way as possible.
Thanks very much indeed. A couple of general questions now. One is, what's the difference between CLL and SLL? And does one automatically lead to the other? And is the treatment the same for both?
No, they're the same. They should be reviewed. They should be viewed as the same. If you're going to be a purist, SLL is a subtype of CLL. So CLL is the correct term. SLL is just a nodal disease without evidence of disease in the blood. Virtually all SLL patients will have bone marrow disease, but for whatever reason, it doesn't come out into the blood. It has no prognostic significance and it has no difference in terms of treatment, with the exception that sometimes trials, particularly commercial trials, will exclude SLL patients because they have no circulating disease, which I don't think is in any way reasonable, but it can be an issue. But for routine treatment, and certainly things like the FLAIR trial, we accept people who've got that. So no, they're the same.
Thank you. We're almost out of time. Can I throw perhaps one or two questions at you, which are again general questions? Do you foresee a time when chemotherapy will be replaced by the new oral treatments for patients? And would you like to see that happen?
I suppose the aim is that we cure people with the least toxicity, and I'm agnostic in terms of how we get there. As I said in the talk, I don't think we should necessarily just say we move aside from FCR. I mean, I'm not a patient, but 6 months of FCR chemotherapy followed by a lifetime of remission seems like quite a good deal compared to taking a therapy that you have to take continuously with side effects. I think it's clear that the toxicity profile and the efficacy of some of the new treatments means that on a practical level, we can deliver effective treatment to more patients. You cannot give FCR to most patients with CLL. And so, as much as it might be a great treatment, it's just undeliverable. So I think that we will see that there will be a move towards using combination treatment. I think we'll see a move towards trying to get time-limited treatment whereby we can achieve MRD negativity so they won't have to give therapy forever. I don't think we've seen the end of FCR, but I think that some of these questions will be addressed by if we can find a genetic signature that reliably allows you to say, here's a person who needs ibrutinib, here's a person who needs FCR, here's somebody who needs combination treatment, or here's somebody who needs something completely new. That's where we should be going to. And I think that, we might be curing some people. I mean, it's always, can CLL be cured? We don't know, but there are certainly a signal that some people, if you're in an MRD negative remission for 20 years, then you probably are. And that's where we should get to. I don't mind how we get there.
Okay, thank you very much indeed. I think we better close there because I know everyone on the panel has other things to do and time is very, very precious. So finally, I'd like to thank all our panelists today, Professor Bloor, Robin Edward, our patient, Dominic Pavinka, and Rob Costa, and everyone else for tuning in.